I am delighted to welcome you to our health equity event, one of two health equity events we hold each year. But I am even more delighted, and I apologize to our wonderful speakers and everybody who organized this, to welcome you to this space. This is the first event we have had in our brand new space here on 17th Street. And we are just thrilled to be here. A special shout out to Shannon Robinson and our events team for making it all happen, which is really hard when it's the first time and no one has ever done it before. So the Wagner School holds 2 health equity events a year because health equity is so critical to thinking about health policy and management. We are particularly excited that this year we are welcoming our MHA immersion students. Raise your hands. Yay to their in-person class here today to get to meet one another. What the topic today is about place. And those of you who live here in New York City or who are anywhere, actually, you know, but here in New York, it's so evident that as you move from one neighborhood to another, the resources that are available to people are very different. And those resources affect the social determinants of health, which we know are really important to people's outcomes. So that's going to be the topic of conversation today. I am really excited to invite our moderator, Giovanney Mendoza, current MHA student, to introduce the panel and get our day started. Welcome to 17th Street.
Hi, good morning, everyone. I'm Giovanney, academically current Wagner student. I'm also a clinical social worker at Mount Sinai, joining us today on this panel. There we go. Let me see. Joining us on our panel today to talk about the place principle is Dr. Olubenga Ogedegbe, who is a founding director at the Institute of Excellence in Health Equity at NYU Langone Health. He is a clinical epidemiologist, health services researcher, behavioral scientist, and global health scholar with expertise in implementation science and translation of evidence-based public health interventions into clinical practices and community settings to reduce the burden of cardiovascular diseases in the United States and in Africa. Joining us as well is Lynn Mertz, PhD, Senior Strategic Policy Advisor of Global Thought Leadership and Health Equity at AARP. She is a Strategic Policy Advisor with the AARP Global Thought Leadership team. In her role, she partners with business unit leads to address areas of disparity, housing, and healthcare facing older adults. She is an experienced strategic advisor with a strong commitment to health disparities from a solutions-oriented perspective. To start everyone off as well, we'd like to do like a quick icebreaker. Just shake the hand of the person to your left and right and introduce yourselves really quickly. Let's open it up a little bit.
Good to see you. It's a good one. Yeah. Success.
There we go. Great. Really? All right. I know, right? Great. So let's really kick things off here. If we could. All right. Perfect. So to kick off, I'm going to start with you, Lynn, here. If you would like to go into your explanation of what you consider the place principle to be and why this is critical when discussing health equity in urban settings like New York City or similar equivalents, if you will.
Sure. Thank you very much. And thank you for having me be part of this panel today. I appreciate it. And I'm honored to be able to come and talk to you. As I was coming here today, it was reminding me of when I was coming to Wagner as a student. It was in Washington Square, so it was definitely not here in that older building. But I came to NYU and I wanted to pursue my master's here because I was working in Newark at a community development corporation at the time, one that was created as, kind of in the aftermath of the riots that were happening there. when the community wanted to come together and say, how do we reclaim what we want for our life? And I wasn't from that neighborhood, and had the opportunity to work there, but it wasn't my history so much. And so I chose to come. I saw the program that NYU had, and I was like, this is the way to backfill and for me to be able to learn and to better appreciate this and give me the tools that I needed to be able to best support the community there. So that was a lot of my little journey also coming here today, because the reminders of that. And when I was talking to Tiffany earlier, just how much has changed over the years. And when I was in, but I think about the place principle, and I think about that role of community, and New Community Corporation got to be what it was and was able to create viable, communities there because everyone came together. And they came together, said, we don't just need buildings, we need jobs, we need education, we need healthcare, we need community, and they did that work together. And I thought it also manifests at the time of the Rodney King incident in LA, that's when I was in school here. And I remember Professor Mitchell Moss passing on a reporter to me, because they called him as the expert that he is and said, what's going on in Newark? And he's like, I'm not sure, but a student might know, and was able to pass that, which was really empowering. But what happened then during that time is all of the seniors in all the buildings came out and occupied the grocery store to protect it, because they worked too hard to bring a grocery store to their neighborhood. And I think that's a lot of what principle of place, you can take it to how that helps their health and all, the other health equity part, but it's ownership, and it's coming together as a community to do that work. So always,
Yeah.
I could keep on talking, but there's no need. Yeah.
Thank you. What about you, Benga? Have you seen anything that you find critical when discussing health equity in places like New York specifically?
I have to say first, let me just thank Cheryl. She was my teacher, and I was doing my MPH in 1999. 98, 99, just finished my residency at the time. And also when I came to NYU Langone Health, John Billings was actually one of my mentors. And I remember coming down here to sit down with John, look at those data. I'm like, what does this mean? I couldn't even make sense of it. But now we do, because what really happens is, I don't know if this mic is working. It's working. I think for me, we have to start from the place of privilege. To do the work of health equity in a city that has been doing this work forever, it makes it feel as if it's a lived experience. It's what we do here. So I don't know that it's what I needed to add, but it's the contrast I want to draw to some of my colleagues who are doing a similar work in a state that doesn't give you the ability to actually make impact with the kind of work we do. So I think, we're fortunate to be in New York City. We're fortunate to be in New York State and then New York City. The policies, no matter how painful they may seem to us, when you take a relative lens at that, you begin to appreciate that we truly have something going. The key issue now is, how do we sustain that in light of a lot of the policies that are coming down from the federal government?
Yeah. And I think that's a really great point that you bring up too, when you're considering the landscape that we are heading into. And in that vein, Benga, how does the intersectionality of race, ethnicity, and income level further complicate health outcomes in certain places? What are you seeing out there that is at the forefront?
It's a great question. We don't talk about this enough. I think we talk about things in linear sense. Then the beauty of policy is that it grabs almost everything. But if you think about it that way, right? So let me be more concrete. If it is true, which we know it is, that where you live matters in terms of your health outcomes, at least data has shown that. Stephen Wolf from Virginia Commonwealth University actually just published an update of their paper it's now called The 10 Americas. The interesting sense in that paper is that regardless of your race or ethnicity or your socioeconomic status, the place you live, the zip code, is a better predictor of your life expectancy. So if you live in Appalachia and you're white, your expectancy is much lower than if you're a Black person living in New York City, in the segregated parts of the city. So think about that for a second. If you're Native American, it's a different story. The idea behind all of that is to show that if you live in a rural setting in Appalachia, there are 10 of these categories. In an unsegregated section of an urban area, if you begin to add on that your race and your ethnicity, your language concordance, we're creating intersections. But we don't think in intersections, do we? At least as a physician, I can speak for myself. I see a patient, is that you have high blood pressure or you don't have it? And we began to understand that when we looked at the data, there's something called comorbidity. Is there an intersection between your particular disease and your age or other communicable diseases that are associated with that? And we saw that was actually influencing outcomes. It's the same thing here. The intersection of race, of where you live, of actually whether or not you have a disability or what your identity may be actually matters. And I think that intersectionality is key for us. The most powerful part of that is age, right? I'm saying that because Lynn is here. Could choose any other thing, right? When you think about that, you've worked for 30 years, you're retired. Where you go to retire really matters, at least in this country. Because what tends to happen is you have policies in place that support people like you. And this is why policy is crucial in everything that we talk about. Because if we don't have policies, you can't move people from place to place. You need structural policies that can help us take away those structural inequities. So for me, intersectionality is key, is everything. And I'll give you a last example I think everybody can relate to. So the Joint Commission about 2 years ago mandated every healthcare system to collect data on health-related social needs. Something we've known for a very long time. It wasn't an accident when Professor Glid actually helped with the Affordable Care Act in crafting that language that everybody should have access to care. That's a major social determinant of health, right? The access, though, is not enough. The quality of care you receive also matters. That's what Dean Grossman will often tell me. Health equity means nothing without quality. So we can give you access to bad care, or we can actually, if you don't have access, use the safety net primary health centers, FPSCs they call them. You may have a better outcome than you have access to really bad care. But when they say we should collect that data, we began to ask the question, what do we do with this data? We know that the health-related social needs are major drivers of health inequities. I'm not talking race ethnicity here, if you guys know where I'm headed with this, because that's independent of all of these factors. The key then becomes, what do we do with this data? And the point I'm trying to make is that that kind of data allows us to begin to look deeper into our data set. So is it true that people who are language discordant, they don't speak English language, and they're being seen in an acute care setting? Does that make a difference? Should we be focusing on those folks much more than we do if somebody else speaks English language? And the answer from our perspective is that it's not so much about the people, it's can we have a system in place that can actually identify those needs and then begin to put care processes that can make things different. And I think that's how we have to think about the work of health equity. But we need policies to allow us to make that happen. That policy alone made sure that every hospital today in the country is collecting that data. If you collect such a data, you can guess where they're going next. What are you doing about it? Who are you working with? How do you make sure that after addressing that, people's outcomes are improved? So I think policies like this make a difference. I'm deeply worried that, in 2 years' time, when we hope for recertification, some healthcare institutions will do a better job than others because the government may not mandate that anymore. And those are the things we need to start thinking about when we think about intersectionality. So I can go on and on, but it's just a fascinating topic.
It is, and I think, and my head is spinning on a lot of different things that you're saying too. And part of it is, I think a great gift on where we are now than we were years ago was the data, the quality of the data, and the ability to really disaggregate it. And so we might know that 40% are achieving X, but who makes up that 40%? And how do we work on changing that now? It would be my hope if, it kind of glass half empty, glass half full. But now that we have that information and we can see the benefit on how to be useful and to make improvements, and that it's not just helping that particular person, but it's helping the community. And I was thinking of wearing my AARP kind of hat on now in particular is our whole purpose is to make sure that people can live healthy lives, live longer, healthy lives. Then it's kind of it's not just about living longer, but we want more healthy years out of and how do we get to that? And to make sure that everybody has that opportunity to live longer, healthy lives, which is the challenge as you're talking about where people live and how long, they can, how many people get to be 65. Not just, and so some of my colleagues are doing a lot of work around the area of geroscience and just to make sure that it's inclusive and it's not just like billionaire medicine, but how do we all carry along? So a couple of years ago, I was kind of helped with a project that we supported called the LEAD Collaborative, which was Leaders in Equity and Diversity. And this was a project in the Mid-Atlantic, so from New Jersey down to Virginia. We pulled together 30 organizations. It was the brainchild of a physician, of a hospital director in Western Maryland, who said, I want to pull people, all kinds of groups together to try to address health equity, however that shows up in your community and your organization. And I say it that way, that it's very different than having 30 hospitals and their quality staff person all looking at hypertension, or at blood pressure, but everyone showed up with what their need was. And so we did have hospitals and we had community-based organizations and nonprofits and FQHCs and senior housing organizations. And they didn't need to pick on something that was related to older adults, even though we were supporting this work, because we knew that it's about the lifespan. And if we can help folks along the way. And the truth was actually when we ran the data, the vast majority of lives impacted through this program were 50 plus, but because that's kind of the majority of the health, the patients in the healthcare system in a lot of ways right now. But if somebody wanted to do maternal health as their focus, we said, great, that's perfect. So one of the groups in particular was a nonprofit housing organization that has housing primarily in New Jersey, but also in the Mid-Atlantic area. And they were realizing, particularly for the residents in their low-income housing, that they were not having good access to health care. So they just partnered with a company that would basically bring the healthcare to the buildings there. And they started with a very small project because that was the idea. This was an 18-month intervention, and health equity is not going to get solved in 18 months. But it could get started. And our other real goal, though, was how do we create an ecosystem and have people come in as a community, kind of from the thread that we were talking about earlier, and all take on their challenges, support each other, but they're all doing their own work. So this project has now grown for Spring Point, that it's across all of their low-income housing units where they've brought in a clinic and they've realized the value of, transportation is such a challenge, right? It's such a barrier. It falls apart so easily, particularly for low-income people. For whatever reason, they come up with a plan and it doesn't happen. That to be able to erase that, they've improved the quality of health of their residents, as well as the peace of mind that the residents know that there's something that they can access. So it was just an example that I was thinking of to share. Mm-hmm.
Yeah, I like that example because I think it talks about the importance, which we probably will touch on this at some point, of how do you partner with community-based organizations to do this work. Some of the things that we're testing in our health system, again, NIH-funded studies, we're asking the question, what is the impact of a community clinic linkage model in how we treat patients with comorbid conditions? And to put it a bit more to be more clear about it, the idea is that if we identify a social need, it's not enough to refer people to the community-based organization who do this work for a living. We've got to figure out a way to track that data back to us. Mm-hmm. Because you're still in my patient panel anyways. And if I'm being reimbursed based on population health needs, then I really need to have a sense for what happened when we sent Benga to go see Dr. Mansu's CBO that's focused on addressing transportation issues. An exemplar. It doesn't have a CBO yet, but it works with all of them. I would want to know what happened to him. Did he get the referral done? Did they really address that issue? If they did, then we can better say, how does that affect our health outcome? So with Dr. Fritz Francois advising for hospital operations, actually, we signed a contract with God's Love We Deliver. So that's an organization that really focuses on food insecurity. And the question was, we know the patients that actually are food insecure. And we know the ones where if they're food insecure, they tend to have really poorer outcomes. If you have diabetes, if you have heart failure, hypertension, not so much, but there's data showing that the intersection of those is a big problem. And so guess what we're finding? Data is very limited. We don't have much to say about it because we have to be clear that we had this the right way. 22% reduction rate in the percent of people who actually get readmitted to the hospital. Somebody shows up, they have heart failure, you take care of them, you send them home, right? Best medicines, best care they can ever receive. But when they go home, they live in a place where, as we just said, place matters, where they don't have access to fresh fruit and vegetables. But if you look at the prescription we give to them, you have to eat healthy. We say all of these things, it's casual to us, right? Because we see it every day. But to that patient, it's not that casual. Even if they have the money, but they live in a place where you can't even walk around to find it easily, that's a problem. I have the money, but guess what? In my zip code, I have heart failure. I don't need any help. I want to stay as healthy as I can. I wish I can walk around and get that fresh fruit and vegetables because I exercise with that, but I can't. It's not even near me at all. So God's Love will deliver. We facilitate that for them. And guess what? The readmission rate for those patients actually dropped. Now we'll see what the data shows us eventually when we have a better large sample size. But a peak is telling us that's what we're saying. If that patient doesn't have God's Love will deliver, guess what's going to happen? They're back in the hospital 10 days' time. And guess what's happening? We're going to lose money because we won't get paid for something that CMS is saying that, listen, this is your ward. Take care of these patients. So I think the intersections of all of these things become very important. We're going to probably see more data. To me, health systems have to figure out a way to contract with the CBOs. At the very least, have a solid relationship whereby we have an ability to share the data back and forth. We're doing a ton of that work at NYU Brooklyn, but we don't talk about this enough because the policy of why this is important is only beginning. We've known this for decades. Professor Glid will say that. But it's only now, as the healthcare cost is rising, we're beginning to appreciate that, listen, we can't do this forever. We've got to figure out a way to blunt this rise in cost of healthcare. And it's something that all of us have to share. And health equity, to me, is at the crux of that issue. I'll give another example. During COVID, the transformation in healthcare delivery as relates to telemedicine skyrocketed. Do you know who got the worst hit of all of that? People in rural setting. Why? Broadband access was just not there. That's digital disparities. And when you begin to think about this intersection, it becomes a problem. So these are things we have to begin to really think about carefully because those are the intersections that can actually make a good job look like a bad one. I think Dr. Marmot put it very well, social epidemiology, that we cannot treat people in a hospital and send them to conditions that make them sick. And that's why the social determinants of health are major factors we need to consider as we think about this job, both structural and individual related ones.
And I want to draw attention to something both of you consistently brought up, which is the use of data, right? And then contextualizing that data beyond the number, looking so far as the individuals, who represent that data, right? And the context behind that, and thinking of that, we know that community engagement and empowerment can contribute to improving health outcomes, like you both noted. How does this show up in the work that you are currently doing? Lynn, if you want to share some.
Sure. Yeah. So I think there's two efforts at AARP that I'd love to be able to talk about, and maybe you all are familiar with it, or maybe you aren't. Do you guys know about the Age-Friendly Communities Network? Okay, so don't pull out your phones now, but at another point, please check it out. This is a huge effort nationwide of where communities come together. It's often at the local level. It's also at the state level. And based on 8 domains, and it has its origins with the World Health Organization, and AARP is the US affiliate for this, that communities come together and say, how are we going to create an age-friendly community? And to be super clear, that doesn't mean it's focused just on seniors. It's age-friendly, and it's everything from walkability audits that you can do to park benches that are accessible and all the rest. But it comes together with a community group to decide what's right for their community and how to make it livable. And our website lists the various communities, and they're all shapes and sizes, and they're all, they cross all different party lines. It's really kind of an agnostic exercise. It's really more a case of people wanting to come together and to come up with a plan on how to better their neighborhood. It's also then scaled, as I said, to the state level. And so then age-friendly policies get integrated right across the board, from transportation to housing to healthcare, et cetera. New York has a vibrant network, both, again, at the local level and at the state level, but they're all across the country. Another tool when we're talking about data is we had the livability index, and AARP's livability index is something that I think is really worth spending some time on and to take a look at. You can put your zip code, your street address in there and determine just how livable your community is based on about 8 factors. Again, it's the transportation, it's safety, it's civic engagement, which is a really powerful one that we don't always talk about or think about, et cetera. And so this can be used for the individual when you're trying to decide, where do I want to live? It can also be used with wearing your policy hat, saying, what are the factors that are causing my community, this zip code area, to be lower than in other places? And it can also see, what is your civic engagement? Do you have enough people registered to vote? Or not enough people, but I mean, are people registered? Are they voting? Are they engaged? And I think that can be a tool, if you're not familiar with it, that could be really useful for you. I think it's about 10 years old now, and every year they keep improving it. The data is pulled from sources that can be used across the country so that you're pretty much as close as possible comparing apples to apples, which is useful and is helpful for you. But I think not enough people use it from a policy perspective, rather than just looking at my neighborhood and saying, oh, crime's up, this is a bummer, but it's like, so what do I do with it? And you've got some great resources there.
Yeah, this is very fascinating. I wish I had my phone here, because that's a funding source, right?
We have a new CEO, and the guy who's really the brainchild of our livability index is getting ready to give her score. And I was like, but we've got to tell her it's not just about, gee, did I pick a good new neighborhood to move into, but how is this a policy tool for us? So it's interesting coming up with a short email to a new executive to say, yeah, this is where you chose to live.
So in my case, we actually have a program now called Restore, the Restore Network. The American Heart Association, about 3 years ago, came out with a bold statement that they want to fund what they call the Health Equity Research Network. And the idea was to prevent hypertension in Black communities. So a bunch of us got together and said, look, this is a one-in-a-lifetime opportunity to actually do work that cuts across different institutions. So we proposed, with us leading the program, to actually look at 4 aspects of how we care for people. And I'll talk about the communities in a second. One was that our belief was that if you want to reduce the racial disparities around hypertension, you've got to start by preventing it. We can treat it. Again, we've talked about place and how that affects what happens to you. And we looked at the data. It became clear that most of the urban cities and rural settings actually are where you see the highest rates of hypertension. So we looked at New York City, we looked at Baltimore, we looked at Alabama, Birmingham on the outskirts of it, and then we looked at Detroit. And then we looked at what they call the food apartheid regions. I call it food deserts in northern Boston, okay? And we came together and formed this network. We got the award, and the goals are very simple. How do we partner with communities to actually increase the rate of uptake of lifestyle counseling? And we did this looking at 3 major areas. We understand that the community clinic linkage is key, which means we've got to work with communities. And so we have a community engagement call led by folks in Hopkins, Lisa Cooper, that allows us to bring together a variety of community-based organizations who then advise us on how we can actually work with the communities. Some of us have done that forever, but it's not the same when you work with advocates who've been working with them, who have a better trust with them than you. The second thing we said was that it's going to be important to do this in settings where people ordinarily don't talk about health, but they spend significant amount of time. So for New York City, we used barbershops. So Dr. Joe Ravenel has made this a passion of his life for the past, since I've known him actually. And so Joe at this time had a grant through New York City Department of Health in Staten Island. I don't know if you guys know Staten Island. It's still a highly segregated neighborhood. And so the question was, for Black men there, what is the rate of hypertension control? It's really bad. And so what Joe was doing was working with the barbershops where we can screen people. And if they have elevated blood pressure, not hypertensive yet, then you can integrate lifestyle counseling, working with the CBO they're called CHASI, to actually navigate people to care. So that's one. The second one was in Birmingham. And the question there was very simple. Most places that are rural, transportation is often by driving. So the ability to have physical activity is just not there. And so we're working with the churches. Now I have a faith-based organization there with Andrea Sherrington to actually, this is just hold your breath here. We want to pay the churches, okay, to have lifestyle coaches in them. And it sounded off. Why would we pay churches to talk to their congregants about physical activity? It became clear that because you don't have enough gyms in the area, because you don't have walkways and pathways that people can walk safely, and they keep getting recommended to exercise. You have to drive to the mall to do that. Not everybody can afford the gas to do that. So what we know, they go to church every Sunday, sometimes even 3 times a week. So why not integrate that into the setting? And then the third group was in Detroit. So Phil Levy, an emergency medicine doc, at the time had done some work where he was working using mobile vans to go to what they call the so-called difficult to reach neighborhoods, working with a health plan called Molina Health. So I said, look, we know where those patients are who show up. This is COVID period, if you remember, and they had high fatality rates. And so the question then becomes, how do you reach them? So with mobile vans, you have a nurse, you have a community health worker on the van, and you can screen people for cardiovascular disease risk. And then the fourth one was actually in Boston, where the question there was very simple. If you have food deserts, then maybe what we need to do is to make sure that you can actually, using Amazon Fresh, get fresh and vegetables to their homes, and then have a community-based counselor, diet coach to work with families. And of course, the fifth one was just technology, working with the FQHC. So the point I'm making is that in working with these communities in the past 3 years, it's amazing what we've learned. And to us, if we can show that this works, hopefully the adoption of this and the dissemination will be something that we can negotiate with local departments of health to adopt that strategy as well.
Yeah. These are really great initiatives that you both have presented and work being done at that level, right? To rope in these communities to make sure we're not alienating them and we're serving them in the ways that would be the most beneficial for just quality of life. And looking ahead, what do you both see as the most promising initiatives for closing the health equity gap driven by location? Kind of like you spoken to a little bit, Benga,
Yeah.
in what you were doing and what you were seeing in Boston.
I think several things have to happen. And so the 4 conditions we had for the Restore Network was that researchers like us must provide the evidence for policymakers to do their job. I have this cartoon that I show in some of the talks I give, where you have a guy in the balloon, okay? He's lost. And there's a guy on the lake who is fishing. Balloon guy said, hey, where am I? The guy on the lake said, you're 30 feet above the ground. The guy said, you know, you must be a researcher. The guy on the lake said, how do you know that? He said, because the answer you gave me is completely useless. I don't know what to do with it. The guy on the lake said, you must be a policymaker. He said, how do you know? Because you don't know where you're going and you're blaming me. So the point is, if we don't come together, we won't do a good job. So we must provide the evidence for policymakers to make things happen. Number 2, health plans must incentivize these programs. To be fair with you, health systems are not paid for these things. Now, because you have bundled care, it's becoming clear to us that to improve population health outcomes, you've got to do a whole host of other things that actually support the care of people. But it's not reimbursed yet. Nobody pays you for screening for social needs, most if you refer people. The CBOs are also overwhelmed in what is happening. And then the third thing that has to happen is that we've got to work with the communities. So I think that if I can assert, I think it will be crucial for health systems to begin to work with CBOs in a way where we can contract them, the small organizations, to be an extension of what we do. Of course, there are risks to that, but this is where policy becomes very important. If that is reimbursed, it may actually help us to get there. Some health plans actually do have CBOs that they work with, but it's again a bit artificial in the sense that it's disjointed from the health system. So there has to be a way to have that partnership. So the work we do, at least in my lab, is to provide more evidence for that kind of work. We're doing a study now. We hope we get it funded, led by Dr. Ravenel, where we're looking, can you use barbershops and a department chair for ophthalmology to screen people for diabetic retinopathy? Nobody wants to come to the hospital. My mother died of a massive stroke. I mean, you're going to have to beg that woman to go to the hospital. For them, a hospital is where people go to die. And so it's not pretty, right? So we need to figure out a way to decentralize where we provide care. Ambulatory care networks are going to be crucial, in my opinion, for where we can begin to reimagine healthcare. So that's my own read of the tea leaves. Thank you.
And I think a couple thoughts that don't necessarily relate to specific policy, but one of them is the role of building trust, you know, and you talk about that a number of times you were talking about that, and that's not to be minimized at all. And I think the other is to involve the community that you want to work with, not for, but have them at the table right at the very beginning point. The Spring Point Housing, which I referred to in the earlier, they asked their residents what is it that they wanted and needed, and they involved them in the planning process. And so and if we don't look at and to do things that way, that it kind of goes back to your cartoon in a different way, but you've got this massive disconnect with the fisherman and the person in the balloon. And so if they're not at the table, whoever that they are, or if we're not at the table together, then we're kind of all wasting our time.
Yeah.
But when we are, it's productive and it all around,
Yes,
you know.
it's like
and
magic.
It just makes a heck of a lot more sense. And then you're just doing things smart rather than doing that. Like another example from the LEAD Collaborative was this rural health system that when they disaggregated their data, they discovered about the food insecurity that it happened to be folks who were of Haitian descent. And it's otherwise a predominantly white rural area. And so what that told them is the kind of food that they needed to provide needed to be culturally useful. rather than giving cans of food that they didn't want to eat, didn't know what,
Mhm.
and so, but by engaging them in the process, then they were actually being productive and everyone was helping out. So it's just
Yeah.
smarter. I think at a bigger level, when we were talking about this question of policy, the one that comes to my mind that I would like us to think about a lot more is the use of multi-sector plans for aging. So through all the work that we're doing, the rate of aging is significant. In 10 years, I think the data is that there's going to be more people in this country that are over 65 than under 18.
Wow.
So, and I'm kind of pausing intentionally just to kind of digest that for a second, because then is everything that we're thinking and talking about really designed to serve children under 18 or adults over 65? And I'm not saying anything negative about the 0 to 18-year-olds, but just to kind of think how much are what we're doing also is designed to serve, whether it's the kind of complex healthcare conditions, again, which we
Indeed.
could go down to housing, to transportation. And there is a movement of these multi-sector plans. Sometimes they used to be called master plans. They've been renamed. The idea of multi-sector is that you've got multiple sectors at the table planning it together. So we were joking earlier, is like these terms are used interchangeably in different sector, in different audiences. And so what does it mean this time when I use the word multi-sector? And that's, it's cross-departmental, it's cross-agency, but with the goal obviously being to improve the efficiency of what we're doing, as well as the lives and the livelihood of all of us.
In fact,
yeah.
I think if you look in Africa,
Mhm.
the median age, depends on where you are, but on the whole, is between 17 and 19.
Right.
It's a continent of 1.2 billion people. So now, if you're older than 55, I won't go near 65 yet. System doesn't know what to do. Because even though it's a smaller group,
Exactly. Yep.
but that smaller group actually contributes to most of the wisdom
For
culturally
sure. Yeah.
on that continent. So,
Yeah.
and then if you go to Europe, it's zero population growth.
Right.
Stuff you're talking about that may happen here is
Uh-huh.
already happened there. So these
Yeah.
are real issues everywhere we
And
go.
in the case of Africa, it's not going to be that much longer than when you think about when those 18-year-olds are now in that place. And so
So
the
you have to
average,
plan. WHO is worried
yes,
that
they have.
they have to be able to begin to
Yeah.
have this multi-sectoral approach
Yeah.
in how we look at things. Just buttressing the point you just made.
Yeah, for sure.
Yeah. And then I think, looking forward and looking at recent headlines, why should health equity initiatives continue when inclusive practices are being challenged, right? How does this work continue? Why is this important at this particular moment in time?
It's more important than ever, I think is what comes to me. We might need to do things differently, but it's more important than ever to keep doing it. And I think one of my thoughts on reflecting for today's panel and the conversation that you and I were having earlier was, I think the role of community engagement and partners and within the networks, the hospitals, the health systems, the community organizations, that's where the work is going to get done. And so there's obviously a very significant concern about cuts coming from federal budgets, and not to minimize that, but on the other hand, there's so many examples, and I tried to intentionally pull examples today where the work that is happening that's addressing health equity is not being funded at the federal level. And so, and right from when I was working with the community in Newark at that time, they scrapped and did everything they possibly could without any federal support. So I think we have to kind of hold on to those examples of success that went through huge barriers. Again, if back to 40, 50 years ago at New Community, those were, incredibly difficult, challenging times, and what they overcame and the successes that are there now. So I think that's where we have to kind of remind ourselves, and then clear-headed looking forward, and keeping the human focus on all of this. I was thinking of an example of community health worker that is working in this one project in a health system in Virginia and Richmond, And part of his role is just to kind of check in with the patient when they show into the emergency department. It's a human element. This person was a patient, he tells a story, was having great anxiety and fear. They didn't, of being admitted to the hospital because it was time to pay their rent. And you can't do that from the hospital bed. And they didn't have a way of an electronic payment. The housing system didn't. And so the community health worker helped facilitate that payment and or the extension, and that gave that person peace of mind to be able to just deal with the crisis of the health at the time. I mean, it's a really human response. And I think those are the ones that are going to help carry the day too.
I couldn't agree more. So I run an institute for excellence in health equity. So for folks like me, you know, is a target already.
Sure.
But I'll tell you what I think we need to do, in my opinion. This is not new, right?
Exactly.
So when I embarked on my career to do what we would call at the time health disparities research of minority health, it was purposeful. I remember being told that is not science. And I told my chief at the time, well, you know, if we get grants with this kind of grant, with this kind of work, would you consider that science? He goes, yeah, let's see if you get them. And so what we did, right? Because it was important work, right? For those of us who've been in the trenches, this is a lived experience. We're not just talking. These are people you see every day. I think the most important thing we have to do, though, is dig deep and go back to the days where even the word health equity, people didn't know what that meant.
Right.
And we must educate everybody about what health equity is. So if there's one wish I have, it is that we have the ability today, tomorrow, to talk to every single person about what health equity is. I want to take a chance to do that now. Health equity is defined as a fair chance for anybody, regardless of your background, to achieve the best possible health outcome. Why won't anybody buy into that? Let's just think about that for a second. I think what's been going on is that you conflate such programs with, when people hear the word diversity, it's an important aspect of what happens in the workforce. People tell me all the time, Benga, there's data showing that if a Black patient sees a Black provider, they do much better. Our data shows something similar, but not in terms of the outcomes we're looking at. Then I asked the person, I said, okay, how many Black doctors are there? So, well, you know, maybe we constitute 4% of the physician population. Great. How many Black folks are in the country? Maybe just 12%, 13%. I said, great. You really think we can provide, you know, enough Black doctors in the country to actually make sure that you see a Black doc? They said, no, but I said, so that's an aspiration. What I'm proposing is that we have a culturally inclusive workforce that allows us, regardless of your race, to be able to take care of people that belong to different cultures. I think it's how we frame the program. Affordable Care Act, I'm see Dr. Glede is here. The idea was to provide access to care, which we know and data has showed, thankfully, between 2013 and where we are today, data has shown significantly that it improved life expectancy, name the disease. It's done an incredible job. How is that a problem? Well, it's a problem because we never defined for people what health equity is. I think this is the time for all of us and the students in the audience. So please, make sure anybody you meet, friends, family, we need to educate everyone about what health equity is. If you're living with disability today, as we speak, think about that for a second. Somebody is wheelchair bound, or they have communicating disorder, or they have a hearing loss. Health equity is the reason why they will do as well as somebody who doesn't live with those disabilities. How is that a bad thing? If you're in Appalachia today, where the education that people have is not up to par, where you have to travel, even if you can drive, the complexity of the transportation in those settings is even more severe, particularly in inclement weather. Why won't you have telemedicine or work with community-based organizations to provide care for those people? How is that a bad thing? And then finally, if you're seeing somebody in your healthcare system who cannot speak English, how is it a bad thing to have language preference for people when we can afford it with technology, particularly in the setting of artificial intelligence? I believe what we need to do is to actually educate people about what health equity is. We should have shingles everywhere because health equity touches every single one of us in this room, regardless of who we are. Why? Because all of the domains are what we've been talking about today. And those are the things that are non-health focused that affects people's lives. So I'm actually optimistic, believe it or not, because I think it's an opportunity for us to do the things we should have done without having some policy wielded over our heads. And I hope that with that optimism and enthusiasm, we can actually convey why it is important to be in this space.
Thank you for that. And I think something that you both said that I come back to and has sat with me is this idea of going back to the idea of community and relying on that community to start helping us pave the way forward, right? Thinking of including those who know best to navigate these areas to guide where we're gonna go next. And I thank you both for a lot of your responses to these questions. And now I want to throw it out to the Wagner students if they have any questions. Yeah. If you keep your hand raised, actually, so that way we know where you are.
Hi, thank you. This is a really fascinating discussion. I'm glad to hear from you. I work for a research foundation, and we fund grants, scientific grants around the world, largely in the US. And we have multi-million-dollar investments in disparities-related work to close the gap in outcomes, specifically for Black women in a certain disease. So I'm curious, especially from an institution like NYU Langone, really, like, practically speaking, given the news changing every single day, we are also bracing ourselves for how do we continue funding this research if the institutions we fund are no longer able to accept our funding without sacrificing their multi-million dollar grants from NIH. So if NIH says, we will not give you these grants, which are much, much larger than the grants that we give them, how do we continue this work in this country? And how, I'd be curious to hear a place like NYU and of course the Institute for Excellence in Health Equity, how are you really bracing yourselves for the potential loss of funding from NIH? And then how do nonprofits who can't remotely fill that huge gap help?
I think that's a great question. I'm not Pollyannish about the threat. I just said we have an institute that's heavily funded by the NIH. I would say this though, given the data that we have currently, we're fortunate at NYU to be a private institution. Of course, 75% of our funding at the last count is NIH funded. And that's by design because we're a place of excellence as most institutions. To answer your questions, I have to show the relative. If you're a state, let's leave the state out. If you're a school of public health, okay, that relies on tuition and endowment, and you're heavily funded by the NIH, not in New York City, that's a big problem because that's funding that goes away and the tuition revenue will not support, just can't, right? So that's, when I talk to my colleagues in those settings, I worry more about them. Because the beauty for us in our healthcare system, we have a healthcare system as well. We're fully integrated. That still supports our research. So we're beginning to think about how do we pivot. And there are several strategies, but I'm a little bit reluctant to begin to talk about specific strategies when we don't even have any more information that we need currently. Health equity grants are still funded. All my grants are health equity grants, okay? They've not pulled that funding yet, right? I'm not waiting for them to pull the funding. It's going to be very, in my opinion, difficult to propose one strategy because there's so many factors that affect this. What is being pulled currently is programs that are supposed to train people to provide inclusive care. So any program that targets one group beyond the other, they pull them. Gender-affirmed care is at huge risk. We know that. That's a very specific area where we've got to think about what our strategies could look like. But the research per se in health equity, we've not seen much in that space. The bigger problem we've seen around health equity is USAID. That's been shut down. I do work in global health, and I can guarantee you that that will lead to disruption of the gains we've made, at least in the HIV/AIDS treatment of the past 30 years. Right now in the US, we haven't seen much in that space. If anything, things are in courts. It will take time. I think we're going to have enough time to begin to think about what our pivot strategy could look like. Whatever the strategy, we've got to co-develop that with the scientists. I don't think it can be a top-down thing. And that's my opinion. I'm not speaking for NYU leadership. What I can say for our leadership is that we're in a better place than most institutions. And please, let's work with you to get those funding. Every dollar counts in advancing research.
I think it's from some of what I've been reading and following along, I think philanthropy is being asked to step up and do things differently. And so as a generalization, I'm seeing that more and more of just people asking, there's more going to be a need of direct operational, somebody said, leave the spreadsheets behind, just like how to help very much, plug gaps and or just do things differently. So I do think that probably folks are going to be looking to you and your colleagues to how do we address this differently than we have in the past too. And some of that may be good change to kind of build on the optimistic point of view, but there will be some difficult conversations probably too. Yeah.
Thank you for the question. Yes, more questions from Wagner students.
Hi, my name is Brian Angulo. I am currently a student doing dual degree MPH, MPA, and my question is kind of similar to the previous question, but I'm a little interested in what you're doing in your day-to-day sort of professional lives and how to sort of communicate this issue about health equity and maybe what you think is important for students in this field to really target no matter what position we pursue, in the healthcare space. Thank you.
What we're doing day to day.
Yeah.
So address this issue.
This environment of, importance of.
I've been giving talks. I have no choice. I think the first thing I have to do is make sure that my colleagues at the Institute actually get a sense for how they're feeling. And there's a lot of anxiety going around. And so I think that's the intended purpose of this. When you're anxious, you hunker down. I'm saying that we can't hunker down. We've got to really continue like this never happened. Because if we don't stay hungry on this issue, it's very easy to see things rolled back, even much more dramatically. I see this as an opportunity for us, and that's what I've been telling everybody, to reimagine how we define health equity. I think we have to do what I just did to make sure that everybody is touched. We're not making that up. The data supports that. The other thing I do on a day-to-day is to talk to the ordinary folks. When I mean ordinary, people who don't have the research expertise that I have. So it's a relative term. Are we sure that the security guard at NYU Langone Health knows what health equity is? Are we sure that the caterer, the people who provide the best services that make the life of the patient so much better than just the doctors, right? The little things, I think all of us, am I sure that the Uber driver that takes me home at night, right? Or the bus driver, if I'm taking just transit, how do I talk about health equity to them? Because I think it's important. The other thing we're doing, tell my folks and my friends, call your congressman, call your congresswoman, call your congressperson, and just say, look, this is what is going on, and we're protesting this issue because we think it's important for the lives of people like us. I think that's what we need to do more of. We have to advocate. We have to really, really advocate. It's not something that's linear. I'm reminded of what a reverend priest said, pastor said about Nuremberg. He said, you know, when they came for the Jews, everybody kept quiet. If you don't activate, when they come for you, there'll be nobody left to support you. I paraphrase, but the point I'm making is that all of us have to really work on this one. If Affordable Care Act goes, health equity dies, I don't see how a meaningful citizen can never get the best care in this country. That's key. That is what we're looking at here. It's not anything it's not about race or ethnicity. Of course, that's how it's couched, because that's a straw man. It's beyond that. People with disabilities will suffer a lot. The American Disability Act will mean nothing. Even though it's an act, they're saying we're going to take that away. Without really saying it, but with the policies they're putting in place. So we need to be really vigilant and talk about this as often as we can. I say it in my dreams, actually. So it's that engrossing when I think about it. It's a sad time, but also an opportune time for us to be more activated in how we talk about health equity.
Yeah, I would say ditto to all of that. And, and I think from when you're talking about it from a career perspective, I mean, I think from when I look back on mine, I see a consistent thread of a passion and a commitment to social justice, and it manifests its way sometimes in different ways. But I think that becomes my foundation. That's my anchor for why I'm doing what I'm doing and how I keep moving forward. It's clear, from some of my colleagues that I've been talking with, that I think we also really need a big dose of empathy right now. And we don't really realize how our neighbor is being impacted. My colleague sitting right there, I don't know about a condition that may have that I don't know about that's going to be impacted. So I know that intellectually, like our colleagues have talked about, you're still going about your day and trying to do your thing, but it's draining because their lives have also been personally impacted because some of the affronts that are going on right now. So I think however you're moving forward, do it with a lot of kindness to those to your left and to your right too.
Okay, I understand this is the last question. I just wanted to ask Dr. Ogedegbe, what happened to the man in the bubble and the man fishing? What happened? You didn't tell us. Also,
it's a good metaphor. What happened is that when there's a disconnect between policymakers and researchers, it takes almost 2 decades to translate practice and evidence into practice. We all have different incentives, and I want to get the grants, want to get the papers. The policymaker wants to get the policy done. And so the incentives are different. And so how do we align? This is an opportunity for researchers and policymakers to actually get together and start doing things the way you're all taught here at the Wagner School of Public Policy, because that's really the whole idea of this.
Thank you. And join me in thanking our panelists, Dr. Ogedegbe, Dr. Mertz. Dr. Mertz, keep it going. Unfortunately, Dr. Mayendo could not join us. He is ill this morning, but he is here with us in spirit. We send him goodwill wishes. And join me in thanking our current student, Giovanney Mendoza, who did a fabulous job of moderating this panel. The conversation continues for MHA students as they continue their on-campus event. As you heard here, equity touches all of us. The job now is up to all of us. I hope this leaves you very inspired to continue the work despite of all the headlines. And I look forward to welcoming you back to this space for another event at Wagner. Thank you all.